دكتور رامي وصل كمان. احمد باسم موجود؟
موجود.
صباح الخير، ازيك يا باسم؟ باسم سامعني؟
صباح الخير.
ازيك يا حبيبي، اخبارك ايه؟
دكتور ناصر. 5 4 3 2 1.
Good afternoon, ladies and gentlemen. It gives me great pleasure to welcome all of you in webinar number 19 among the series of webinars organized by the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. I would like to express my sincere appreciation to our distinguished speakers, Professor Dafou Hogas. He is Professor of Neurosurgery and Chairman at the University of Montpellier in France. And I would like to express my sincere appreciation to Professor Bassem Ayoub, Professor of Neurosurgery at Cairo University, and the moderator of this session, Professor Rami Amin, Professor of Neurosurgery at Cairo University, and Professor Omar Youssef, Professor of Neurosurgery at Ain Shams University. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time. Sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. Thank you very much, and special thanks again to Professor Dafou for accepting my invitation and for honoring us by contribution to this webinar. Thank you very much.
Thank you, Dr. Nasser.
Now I will give the word to Professor Rami Amin, the moderator of this session.
Yeah, good evening, everyone. I think we'll start directly with the talk by Professor Dafou Hogas about early maximal safe resection in low-grade gliomas, an experience of over 1,000 awake craniotomies. Please proceed.
Can you see my screen?
Not yet. Okay.
Here it comes.
Yes.
Yeah, we can see it now.
Thank you very much for your invitation. I'm very happy to be for the first time in Egypt, even if virtually. And I hope that we will continue to share in the next years. But for today, I would like to thank you again for giving me this opportunity to talk about my experience for over 20 years regarding low-grade glioma management, especially surgery, about more than 1,000 awake procedures, allowing us with more than 20 years of follow-up to improve both the survival and the quality of life. And we were able to achieve that thanks to the fact that we decided, so 2 decades ago, to do earlier surgery, including, as you will see, in incidental low-grade glioma patients. So that means that we do not apply anymore for many years the wait-and-see attitude. Second, by doing a maximal resection, and you will see that if we can remove more than what we can see on the preoperative FLAIR MRI, what I like to call supratotal resection, we do it when feasible, according to third, of course, safe resection. So preservation of the quality of life of the patient based on the knowledge of the connectome mapped during surgery, thanks to intraoperative awake surgery. So very quickly regarding natural history of the disease, you know that low-grade glioma are not benign tumor. They are growing in all cases, even if in the vast majority of cases in young patients enjoying normal life. and will become malignant by finally inducing a decline of cognitive function and killing the patient with approximately survival between 6 to 7 years by applying the wait and see attitude. Nonetheless, by being more objective, we demonstrated that if you do a neuropsychological assessment in these young patients, in the vast majority of cases, before any treatment, they have already cognitive deficits, especially regarding the executive function, multitasking, attention, emotion, personality. And this is very important in order to make the decision to treat earlier. Indeed, we demonstrated that these deficits due to the tumor is not related to the lobar location of the tumor. This is not because located within so-called Broca's area or Wernicke's area, but due to the infiltration, the invasion along the white matter tracts, which are the limitation of neuroplasticity. In other words, if a patient has already invasion of the ventral semantic pathway, the inferior fronto-occipital fascicle, for instance, before any treatment, once again, then he will have, in the vast majority of cases, already some degrees of semantic disorders. So this is very important, of course, to know that in order to adapt the strategy and to select the task for awake mapping. The next step is that the patient will have seizures. So that means that the stage of brain plasticity is overcompensated already when we started to have these kind of symptoms. Speaking about oncological issues, we know, thanks to Mitch Berger initially, and then we reproduced the results in France about more than 1,500 low-grade glioma patients, that the risk to see malignant transformation and then finally death is directly correlated to the volume of the tumor at diagnosis. But the volume of the tumor is not enough. We have also to calculate objectively the growth rate before to do a treatment, because of course this is not an emergency. We can wait for 1 to 2 months to explain to the patient that he has a chronic disease, that we have to operate, that we will not cure him, that we have to do a neuropsychological assessment, probably a post-operative cognitive rehabilitation, and finally, in 99% cases, he will return to a normal life. In the meantime, we can do 2 MRIs and to calculate objectively the growth rate. And of course, if the tumor is growing faster, that means that the prognosis is worse. But if a tumor is growing slowly, regardless the molecular pattern, that means that the prognosis is very good, especially if we achieved a complete resection according to the post-operative MRI. Indeed, we demonstrated that this growth rate reflecting the intrinsic prognosis of the tumor is not related to the molecular pattern. For instance, you can have very slow growing tumor while you have not IDH1 mutation. And this is the reason why recently we published in Journal of Neurosurgery my series with prospective collection of data of patients operated on with a wild type. And even if in 15% cases the tumor grew like a glioblastoma, in more than 80% of cases, we had no to perform any adjuvant treatment, no radiotherapy, no chemotherapy following a surgery, because we did an extensive resection, because the tumor grew slowly before surgery, and you can see the survival which is very high. I mean, more than 50% with more than 8 years in this subgroup. So in other words, that means that molecular biology is only a part of the story, and that in more than 80% of patients based on wild type in the world, they benefit from a STU protocol for nothing. That's totally crazy. If we are doing just a biopsy followed by chemoradiotherapy, definitely, even in recent series, very honest, which demonstrated that the median survival is, as I told you, 6 to 7 years. In the French glioma, we have the habit, French Glioma Consortium, to do a very extensive and accurate measurement of the volume on the pre-operative imaging, of course, on the flare, but also on the post-operative imaging, in order to be objective and to calculate relationships between the extent of resation and the survival, which is not done in the vast majority of trials. That means that the vast majority of trials in evidence-based medicine are simply totally biased by the fact that in the vast majority of cases, the tumor was not removed. And everything is based on the subjectivity of the surgeon without any objective calculation of the pre and post-operative volume. But if you do the calculation, suddenly we change radically natural history of the disease, about more than 1,000 cases, about a prospective study with median survival more than 15 years. So that means that we were able to double and now to triple the median survival in this patient. This is the reason why median survival is important, but also the quality of life, because they will live more or less one generation. And the secret is to reoperate, reoperate each time the tumor is growing again and again, because definitely we're not able to cure these patients because this is a diffuse glioma and there is no tumor mass, but a diffusion within the brain. And the goal will be to do resection according to functional boundaries in order to do an extensive lobectomy, but also by preserving the quality of life. Nonetheless, the tumor will come back, and then I will do a second surgery by playing with the mechanisms of neuroplasticity. Then the tumor will come back and I will do a third surgery. Now I'm preparing paper, the sole in the literature about third surgery in low-grade glioma with more than 15 years of follow-up. And in this subgroup, the median survival reached approximately 20 years. To do that, no biopsy. If you look, you meet a patient with an MRI very typical for diffuse low-grade glioma, I operate, of course, if the patient agrees. And I will do that by preserving the quality of life, whatever location within the brain, according to a better knowledge of the connectome. And to do that, we need to do mapping techniques before, during, and after surgery. Indeed, the vast majority of these tumors are located within so-called eloquent areas, Broca's area, Wernicke's area, central area, and so on. But in fact, we have to forget it. Localizationism does not exist except in the mind of old neurologists. We have to burn it. It does not work like this. I am PhD in cognitive neuroscience. I am the director of a team of research based on neuroplasticity. And I can tell you that the brain is processing using different networks with interactions between networks allowing plastic mechanisms. This is the reason why I spent my life within so-called eloquent areas, and my rate, as you will see, of severe permanent deficit is less than 1%, because the brain is helping me, because I preserve the brain, because I have understood that localizationism does not exist. And suddenly everything becomes an evidence, including the fact that functional imaging is not the truth at the individual level. I can say that because, once again, I am PhD in this field. And I know that it's beautiful to do research before and after surgery, but understand mechanisms of neuroplasticity to pre-plan a third surgery. But into the operating theater, the value of fMRI is 0. You can see the sensitivity and specificity speaking about language by correlating to intraoperative cortical mapping. This is true also speaking about the new methodology of resting state. We published that because we have probably the most extensive data bank in the world with pre and post-operative resting state functional imaging before and after surgery for low-grade glioma. And nonetheless, I can tell you that the reliability is 85%, which is beautiful to do research as a didactic tool, but not into the OR with 15% of risk to induce a permanent deficit or not to resect the tumor based a priori on functional imaging. This is true for DTI. We compared intraoperative subcortical mapping to pre and post-operative DTI, reliability around 80 to 85%. So it does not work at the individual level. If you do not believe me, please ask to the specialists, the engineers in the world who published recently a paper about 20 research groups demonstrating that the tractogram contained many more invalid than valid bundles. This is not my imagination. So for young people, you cannot say, oh, I will put fMRI DTI into the neural navigator and I know where I am in the brain. This is totally untrue. You have to see the truth in front of you by asking patient to do cognitive tasks online. And then if you do wake mapping by using intraoperative electrical stimulation, both at the cortical and subcortical level, because remember, and I will say that many times in this talk, that the limitation of neuroplasticity are the pathways in the depth, then suddenly you can do cortical subcortical anatomofunctional correlation in real time into the operating theater, and you will reach 99% of good results, even in so-called eloquent areas. So we have, of course, to adapt the good tasks to the good patient, and not only to avoid hemiplegia aphasia. I touch wood, but I have not induced any severe aphasia, hemiplegia for more than 15 years now by doing this kind of surgery many times a week. But it's not enough in order to enjoy a perfect normal life. Remember, median survival, 15 to 20 years. So they need to speak different languages, to make sport, to play piano, what they want, to work according to their definition of quality of life, job, hobby, habits, leisures, and emotional processing. But it's important also according to the environment. I have the habit to receive patients coming from the 5 continents. And of course, the culture, the religion, the mind is totally different, but also the law. For instance, with hemianopia, you cannot drive in France. You can drive in some countries in the world. For instance, if you want a post-operative cognitive rehabilitation in order to improve the quality of life of the patient after an extent, a very massive extent of resection, in France, you are reimbursed. In US, I was yesterday by webinar in UCSF in San Francisco, you are not reimbursed, and so on and so on. But most of all, you have not to continue to think that the risk is related to the lobar location of the tumor, but the risk is in the depth to cut pathways, because if you cut the projection fibers or association fibers, which are the limitation of neuroplasticity, you should imagine that just for 5 more millimeters, you disconnect 2/3 of the hemisphere, and never the patient will recover. And this is the reason why this is the positive message. Everywhere in the world, you can reach these kind of results because I'm not using any technology into the operating theater. No microscope. I have good glasses, no neural navigation, no DTI, no fMRI, no intraoperative MRI, no ECOG, no robot. I need nothing, just my connection to the brain of this patient at a time, thanks to the wake monitoring, and thanks to my knowledge of the connectome of the patient. And that's it. That means that if I can do that, everywhere it's possible to do that. But the problem is that for the vast majority of neurosurgeons, now they agree to do awake surgery, but in the left so-called dominant hemisphere, and to operate under general anesthesia in the right non-dominant hemisphere. I don't know what it means, because I need both hemispheres in order to do surgery or to give this talk in front of you now, and not just my left hemisphere while I am 100% right-handed, because I understood that, of course, in the right so-called non-dominant hemisphere, you have the control of movement. And this is crucial when you are into the war as a surgeon, and when you need bimanual coordination, spatial cognition when you drive, social cognition when you organize a meeting, non-verbal semantics when we are not speaking and nonetheless we can understand, executive function, working memory, to be able to do 2 things simultaneously, personality, the mood, the affect. You will tell me it's impossible to monitor these kind of functions into the OR. Of course, this is possible. This is exactly what we did for more than 15 years now, by asking the patient to do 2 things simultaneously, to combine items, pictures, semantically linked, and so on and so on. Of course, this is possible. And this is a fortiori possible when you are in so-called eloquent areas, because we published in Brain the journal of reference for neurologists already 6 years ago that Broca's area does not exist. And they were obliged to accept this reality because they know that the brain is processing in networks. And thanks to that, that means that you can now add further tasks according to the definition of the quality of life by the patient. For instance, if you're a mathematician, to introduce calculation tasks in addition to moving and speaking. If you are a dancer, if you want to continue to dance following surgery in the right so-called non-dominant hemisphere, you have to do awake surgery and then to map spatial cognition by doing line bisection tasks. If you are a lawyer, judgment. If you are a writer, syntax, and so on and so on. But in all cases, we are human beings. So that means that we are, first of all, emotion. It is possible to map emotion and to monitor it into the operating theater in order to avoid to change the personality. My answer is now yes. And this is the reason why we operate so many patients coming from different countries, because what they want is to preserve a perfect quality of life. And to do that, you need to preserve the connectome. If I speak just about the pyramidal pathways, of course, everyone will understand that if I cut the posterior limb of the internal capsule, the patient will be hemiplegic, will not recover, of course. But is it enough? I'm not speaking about patient. You can take the picture after surgery, able to do that, and then you say, my patient is well. No, I speak about able to play piano if he wants. So higher level of bimanual coordination. And we published recently in Brain a cortical mapping of this network involved in the control of the classical corticospinal tract network. And we know that at the level of the Y matter tract, you have some pathways like the frontostriatal tract. If you stimulate it, the patient will stop to speak, but also to move. And this is true in the right non-dominant hemisphere. But when you operate in the right non-dominant hemisphere, in the parietal lobe, you need also the somatosensory feedback, superficially, protopathic, but also the consciousness, the awareness of body schema. We published that in Brain recently. So if you want to run, for instance, if you love sport, you need to be awake in order to preserve this level of coordination between 4 limbs for a swimmer, for instance, or to play golf. I don't know. They decide. I will give the choice to the patient. Speaking about visual pathway, we spoke about that in France and many countries in the world. To be honest, I don't know in Egypt, but with a myopia, you cannot drive. It's forbidden. So you can say my patient is well, not hemiplegic, of course, but if I cannot drive, in the vast majority of patients, at least in Europe, he will lose his job. So it's not a normal life. Spatial awareness, we spoke about the fact that we had to avoid hemi-neglect. And it's true at the level of the surface, especially the supramarginal gyrus, but most of all at the level of the Y matter tract and the superior longitudinal fascicle. And by doing this seminal report, first of all, we published in Science 15 years ago, but now it became a standard to do line bisection task into the operating theater in order to avoid hemi-neglect, and that works in 99% of cases. Speaking about language, of course, you know that there is a dorsal pathway involved in phonological processing, repetition, but with also a lateral part, which is the superior longitudinal fascicle, involved in articulatory disorders. Anarthria was never related to so-called Broca's area, never. I stimulated Broca's area in 1,000 cases, never I have used it's related to the articulatory loop between the ventral premotor cortex at the level of the posterior part of the left inferior frontal gyrus, namely the lateral part of the pre-central gyrus, and the loop with the supramarginal gyrus. Never Broca's area, anatomically speaking, was connected directly to Wernicke's area. It does not work like this. Once we know that, we have understood also that humans are not like animals and then need to understand the world around, speaking about non-verbal, but also verbal processing. And semantics is mediated by the inferior fronto-occipital fascicle. And when you wake the patient, when you stimulate, you will induce semantic disorders, which is very important, whatever the location of the tumor. I mean, for frontal tumor, an insular tumor, temporal tumor, parietal tumor, an occipital tumor. In all cases, you should be into the contact of the inferior fronto-occipital fascicle at the end of your surgery. Otherwise, you did not remove enough tumor, and the median survival will not be between 15 to 20 years. On the other hand, if you cut it, the patient will talk, but will not be able to understand anymore enough in order to return to a normal life and to work full time. This is the same thing for the inferior longitudinal fascicle. As you know, more basally located. If you cut it, the patient will continue to speak, but it will have an increase of reaction time in order to have a good lexical access. You will tell me it's better maybe to have an increase of speed processing and to enjoy an almost normal life. Of course, maybe it's possible. It's a balance. But we have to ask to the patient before to go to the operating theater and to cut or not more of this pathway according to his definition of the quality of life. Can you consider that your life will be almost okay if you have an increase of reaction time? And of course, everything could be predicted before surgery. And of course, if you use neural navigation or the robot or intraoperative MRI, never this technology will answer to these deep questions. Indeed, technology does not understand yet, at least, the fact that one subnetwork can compensate another one. For instance, you have the IFOF able to compensate the ILF, and then you will have an increase of reaction time for lexical access, but you can do lobectomy at the level of the anterior temporal lobe. And this is what we are doing, not only in the left, but also at the level of the right non-dominant hemisphere. In other words, if you stimulate the right non-dominant hemisphere, the patient will not understand non-verbal processing. But 80% of what we are doing, speaking about the understanding of the environment, of the external world, is not mediated by language. So it's absolutely critical to mix the cognition and the emotion, as I said initially, because we are, first of all, affect, we are human beings. And I changed the personality of patients when I did 20 years ago some surgery under general anesthesia in the right non-dominant hemisphere. And they became depressed. And my masters told me it's normal before they have a brain tumor. No, it's because I got the right IFOF. I was not aware about that, but now my patients are not depressed anymore, even if they have a brain tumor. Because we introduced this new task into the operating theater, you have just to tell me, reading in the ear in front of you, is it sadness, happiness, and so on. And when you stimulate the ventral non-dominant hemisphere pathway, then suddenly the patient will have difficulties for empathy. And you can imagine if you're not able to recognize the emotion of people in front of you. This is very, very simplistically summarized. The model of the right non-dominant hemisphere, speaking about social cognition, emotional processing, empathy, non-verbal semantics, bimanual coordination, and so on. How do you want to monitor that, to map that under general anesthesia? I will tell you, it's impossible. So when we do not propose to the patient to be awake, we lie to the patient. And of course, he can say in the end, I don't want, please remove more tumor. And finally, I don't need to preserve my personality. Okay, so I will remove more. The results, the most important, I did more than 80 diffuse low-grade glioma resection in 800s, I'm sorry, with more than 1,000 awake surgeries in so-called unresectable areas like Broca's area, Wernicke's area, as you can see behind the labia vein, the central area, the corpus callosum, the paralimbic system, and so on. All these patients were considered to be not operable in another departments in 5 continents in the world. Results, mortality 0. I have a good team. It's not forbidden to have good anesthesiologists. Less than 1 of severe permanent deficit. When I was younger, I pushed too much at the level of the anterior perforating substance in the right non-dominant hemisphere because I did that under general anesthesia. I was wrong. Now, no deficit for more than 10 years. 30% of improvement will tell me it's not possible before to remove the Broca's area and to have a patient with a better cognition 3 months later. Of course, this is possible because first of all, remember the neuropsychological examination is not normal in the vast majority of cases if you save time before to go to the OR to do an objective evaluation. And then you will do a post-operative cognitive rehabilitation, pushing neuroplasticity and opening the door to a second surgery or even a third, and then you will increase very significantly the median survival, plus 80% of positive impact on epilepsy, because we have understood that epilepsy is not related to the core of the tumor. If you're under general anesthesia, you're afraid to induce a post-operative deficit and you remove just the middle of the tumor, you will change nothing about oncological outcomes. And in the vast majority of cases, the patient will continue to have seizures. If you remove more around, then in more than 90% cases, you will control seizures. And if it's possible in Montpellier and San Francisco, it's possible everywhere in the world, because probably you know this meta-analysis we did with Mitch Berger 7 years ago, about 8,000 cases operated on under intraoperative mapping or not, and suddenly if you do mapping, you increase the median survival because the externalization, you decrease the risk to induce a severe permanent deficit while operated on patients with tumor within so-called eloquent areas. So the dilemma is solved, and you don't need technology for that. You need just technology in order to better understand the mechanisms. So to do research, in order to apply the research to continue to increase our results. I mean, to do fMRI before and after surgery, and here to explain how the patient can recover after a transitory supplementary motor area syndrome. You know very well, I'm sure. But now the explanation is that there is a contralateral recruitment in addition to the knob of the hand, the somatosensory reentry, the knowledge of the body, what we have seen. So it's a bilateral network. And recently we explained that there was a decrease of the interhemispheric connectivity when the patient has a deficit following surgery, and then will recover thanks to post-operative cognitive rehabilitation. That means that the day after surgery, when I induce a mutism, for instance, in a patient with SMA syndrome, I know that this is a decline of interhemispheric connectivity, and I know how to push the recovery. And this is very important because making the link with oncological issues, I have the habit, once again, to operate, reoperate, reoperate, and it's possible to remove more each time because we induce plasticity in the meantime. Here, for instance, I was not able to remove the knob of the hand in the central gyrus, the so-called, Rolandic system. I don't know what it means, because I was able to remove 5 years later in a patient able to play guitar following the second surgery, thanks to reorganization. It's possible for language too. This is now the modulation of the connectome. We start to understand that the individual level before and after surgery. And of course, it will tell me just research. No. I can apply that in order to say to a patient, I was not able to remove Wernicke's area during the first surgery, but I did a second surgery 10 years later. And of course, in the meantime, the patient enjoyed a normal life, no chemotherapy, no radiotherapy, no malignant transformation. And then I removed completely the left temporal lobe, including Wernicke's area, but I preserved the posterior part of the ILF, the arcuate fascicle, the inferior fronto-occipital fascicle. Normally, you should have in your mental imagery the knowledge of this connectome. This is true for Broca's. I was not able to remove in this patient Broca's area during the first surgery. I hate to lose. I came back 7 years later and I removed Broca's area because in the meantime, the brain changed. And this patient enjoyed a perfect normal life, and we have more than 10 years of life. It's possible sometimes to remove, you see, it's very provocative, both frontal lobe. And this patient has perfect normal life, driving, taking care of children, working from time and so on. But in the meantime, plasticity. And once again, to add more and more tasks into the OR. I know that vast majority of surgeons told me for many years, but you have not a so good excellent authorization. This is the reverse. I remove more because I'm not afraid by the brain. And this is the reason why my median survival is more than 16 years now, with 25% of patients still alive after 20 years. So this is the reason why I'm not afraid to do a supratotal removal. I mean, never think that the flare abnormality is the tumor. This is just the tip of the iceberg. If you can remove more, please do it. You will tell me where are the boundaries, the functional boundaries we have seen. But why to do that? Because with now 15 years of follow-up, I published this paper 4 years ago already, the rate of malignant transformation in supratotalization is 0. So the rate of patients who died in this subgroup is 0, and the patient who had a radiotherapy is 0. So we changed radically natural history of the tumor, and I did not say that I cured them, because in the vast majority of cases, after 5 to 10 years, you start to see again a flare hyper signal. And then what I do, you have understood it, to do another surgery, because in the meantime, mechanisms of neuroplasticity occurred. What I would like now is to increase the number of patients with complete, or if possible, supratotal resection. So I will arrive earlier and earlier. So I propose the screening in the general population in order to have more and more incidental low-grade glioma in my patients. And when we did neuropsychological assessment in patients with incidental discovery, in 60% of cases, they have already disorders. Be careful, because even in incidental discovery, the tumor can suddenly, acutely become malignant. And then, in fine, by doing nothing like in this patient who was followed for 5 years in another institution, when I did surgery, it was too late, because the grade 2 became glioblastoma, while it would have been possible for me to do supratotalization since the beginning. Indeed, about more than 100 patients now with incidental discovery. The rate of supratotalization is 30%, plus 30% of complete resection, plus no partial resection, just subtotal, when sometimes you have to leave already diffusion within the white matter tracts, the limitation of neuroplasticity. No epilepsy. Return to work, we published that in neurosurgery this year, 97% of patients resumed their employment. So it's not just are they hemiplegic or not. We are beyond this kind of consideration. They should enjoy a perfect normal life as if they had no tumor. And of course, with an externalization, more than 95% in the vast majority of cases. So this is the reason why I proposed a few years ago in front of the National Academy of Medicine in France to do screening, and the principle was accepted, and I started so to discover intentionally some tumors. What you have to know is the limitation of neuroplasticity. You have to know before to go to the OR, if you cut this pathway, the arcuate, the SLF, and so on, you have understood, you will induce permanent deficit. Never the robot will give you this kind of information. But we published this kind of atlas in the MNI template, and you can use them in order to build your own atlas in your own brain as a surgeon. Knowing that, sometimes you will say, I cannot remove completely the tumor, otherwise I will get the connectivity, the patient will keep some degrees of permanent deficit. In these cases, please do chemotherapy first, regardless the molecular pattern. In 90% cases, you will have, like here, a shrinkage, even in astrocytoma under chemotherapy. Here, for instance, 10 seizures a day despite 4 antiepileptic drugs, not able to drive, not able to work. I did the first surgery, chemotherapy, second surgery, because in the meantime, there was a shrinkage. Now the patient is enjoying normal life, I mean, working full time, no seizures anymore. It was not an oligodendroglioma. It was a wild type. Indeed, we love evidence-based medicine, but evidence-based medicine told me that if you do early radiotherapy, you will not change the median survival. Evidence-based medicine told me if you do early radiotherapy, you will induce a decline of cognitive function. And this is the reason why I published recently a paper speaking about radiotherapy by telling why to irradiate early, because evidence-based medicine told me if I do early radiotherapy, I will not increase the median survival, but I will decrease the quality of life. So this is totally against the principle to be a medical doctor. They don't know what they irradiate. I know very well radiotherapists. I have been invited in meetings of radiotherapists that they irradiate the brain as they irradiate the breast. We cannot tolerate that. So I do not tolerate. And we demonstrated that if you irradiate, then they induce a deficit related to the fact that the connectivity in the depth, the connectome, the limitation of neuroplasticity, the white matter tract, the myelin will be disrupted, damaged by radiotherapy. And finally, even the URTC published recently a paper aiming to defer radiotherapy for long-term preservation of cognitive functions and quality of life, independently of the 1P9Q status. So this is the reason why in our philosophy, but with 99% of good results and median survival over 16 years in prospective collection of data, then we propose systematically to do an extensive resection when we diagnose a low-grade glioma without waiting, to redo a second surgery because mechanisms of neuroplasticity induced in the meantime thanks to postoperative cognitive rehabilitation, and maybe to reoperate a third time. If there is a diffusion within the white matter tract, the connectivity, then limitation of neuroplasticity, do chemotherapy regardless the molecular biology. And finally, one day we will do radiotherapy, but in our experience, not before 9 to 10 years in the vast majority of cases. And you can see our results now with my young oncologist, never yet published in the literature, but in 1 month now, 16 years of median survival with a Karnofsky status more than 80 between over 12 years. So both survival and quality of life. Never both are mixed in evidence-based medicine. We were very provocative recently by publishing a paper in Neurology telling this is true even if you have some foci of malignant transformation in the middle of low-grade glioma, speaking about grade 3, but also glioblastoma foci, if once again, as I said initially, the tumor grew slowly before surgery, and if you did an extensive resection. You can see that without chemoradiotherapy following surgery, 5-year survival is 95%, including glioblastoma. Example here, high-grade glioma enhancement. I did a complete resection in 22. No chemo, no radiotherapy. I did a second surgery 3 years ago, 15 years later. No chemo, no radiotherapy, because the second time it was a low-grade glioma, while the first time it was a high-grade. Of course, it was not a high-grade. It was a focus of high grade within the low grade. So if you removed the flare plus, then you can change radically the natural history of the disease. And it's possible to push this resection if you know the connectome. So as neurosurgeon, you should be a neuroscientist and to be able to publish in this kind of papers too, in journal, not only Brain or Science, but Nature reviews, to explain to neurologists how the brain is processing, because we are connected to the brain of human being every day into the operating theater. It's not incompatible. And to help younger people, we recently published an atlas, the sole in the world literature, functional atlas, not only of the cortex, but also the white matter tract, regarding critical networks for 16 functional domains. I mean, bimanual coordination, semantics, mentalizing, what we have seen. If you have this kind of atlas in your brain, then you can operate with a fork and a knife and 99% of reliability. And this is the reason why we proposed recently in Physiological Reviews 2 months ago, which is the Bible of human physiology, that localizationism does not exist. And it has been accepted because finally everyone knows that. And the goal is not just to see the network involved in language or movement, but their interactions. And when you are into the operating theater, this is exactly what you do. You can disrupt one network, the patient is not able to move, one network, the patient is not able to speak, but you can disrupt also the interactions between networks. The patient can move, the patient can speak, but not able to do both simultaneously. And if you're aware about that, that means that you will stop in order to avoid to damage what we call the meta-networking brain interactions between different networks. Otherwise, the patient will not be hemiplegic, but will not return to normal life. 97% of our patients are able to work. I don't know if I have to conclude the time to show you a 5-minute movies. You decide for me, and if yes, I can show you how I can remove just in 5 minutes the so-called Broca's area and the left insula under local anesthesia.
Yes, please go ahead.
Yes,
Dafu.
yes, welcome. Yes, yes.
32-year-old man, medical doctor who had an MRI because headaches, a normal clinical examination, and normal neuropsychological examination. You can see the MRI, so that means that the brain can be very plastic because it was able to compensate everything. And we decided, of course, to do an awake mapping according to what I showed you. I will try to. Okay, so the patient is in lateral position, the anterior part is there, posterior part, the temporal lobe, the Sylvian fissure, and the inferior frontal gyrus, namely the so-called Broca's area with the pars opercularis, triangularis, orbitaris. Here you have the ventral premolar cortex, the lateral part of the precentral gyrus. And when I stimulated, as in 100% of patients, then the patient blocked. Anarthria is not related to the Broca's area. Then, of course, I introduced other tasks, naming, but also semantic association tasks in order for the patient to demonstrate that he was still able to understand what he said, plus the movement, dual task, every 4 seconds without any rest, so sustained attention for 1 to 2 hours. So at that time, here, we can identify at the level of the and of course, it will be my limitation at the level of the cortex. But the most important is for you already to imagine that the inferior fronto-occipital fascicle is there, and it will be the danger in the death. Indeed, the surface is very easy. You can see that I have the habit to go very fast, and the goal will be, of course, to preserve the vessels by doing a subpial dissection. You will see that if I remove the microscope, it's because I do not coagulate, just the cortical surface after the negative mapping. And here you have the ascendant ramus of the Sylvian fissure. Here you have the Sylvian fissure itself. I am not so skilled. I do not split the Sylvian fissure, but this is not the goal because the tumor is within the brain. So I am a brain surgeon. I'm not afraid about the brain. So I will disconnect the brain, including the so-called Broca's area, as you can see online, while the patient is, of course, awake. So doing the tasks online. And very quickly, I will do a very extensive resection of the left inferior frontal gyrus. And never, as you can see, I will coagulate. It's forbidden for me to coagulate within the brain, just the cortical surface. And you can believe me or not, but the rate of vascular problem I had these past 10 years is 0. I have no papaverine in my operating theater because I have no spasm, because I am not within the Sylvian fissure. I am outside because I am within the brain and I do subpial resection. So, of course, everything is referred to the lab, and you see that they have material with me because I'm doing a very extensive resection, despite the fact that the patient is moving, doing the semantic association task, naming, switching between 2 languages in his case. And now I will put a retractor, in fact, to have an access to the insula, because you can see the surface of the insula here. And this is the vein at the level of the circular sulcus. And then I will put my retractor at this level in order to do a subpial resection of the insula from inside. exactly what you can see here. And you have now to coagulate, and you have no reason to have any vascular problem if you do that, because you preserve the vessels, and because now the goal will be to preserve the connectivity. And remember, the inferior fronto-occipital fascicle, which will induce semantic disorders when I will stimulate, is running into the temporal stem, so the deep of the insula, but the lateral part of the anterior perforating substance, explaining why I will stop before to be into the contact of the lenticular striate arteries, and why neuroscience, which is sometimes esoteric, will help you into the operating theater by understanding what you are doing and not by being a very skilled neurosurgeon. I don't need to split the Sylvian fissure, but I know how to operate the insula with 99% of reliability. And the patient is still awake during the task and so on. And now I will stimulate because I know I am into the contact of the temporal stem, the ventral semantic pathway, the inferior fronto-occipital fascicle. You call it as you want, but now you need to stimulate, and the answer should be of the neuropsychologist, semantic paraphasia. And at that time, you know that you have to stop. I stimulate. Of course, you have no sound, you have no time, but semantic paraphasia. Okay, I will do again. Semantic paraphasia. Okay, I know where I am. I have to stop. And at that time, you could tell me, but you need intraoperative MRI just to know if there is a small but objective residue in the depth. But I know that there is a residue at the level of the IFOF and the anterior perforating substance. I will not cut the IFOF because the patient will not go to the anterior perforating substance because I don't want to have any vascular problem. So this is the post-operative MRI 1 day following surgery with the so-called Broca's area removed, of course, because it does not exist, but a small objective residue at the level of the anterior perforating substance, which was expected, of course. And I say to the patient, I cannot cure you because he told me I am a medical student. I want to continue to enjoy normal life and to take care of my patients. And then I stopped according to the functional boundaries here with the lateral part of the lentiform nucleus, the extern capsule, and you know that the IFOF is running at the level of the external capsule. So my conclusion is very easy. If I can do that, you can do that if you know the brain and if you adapt the task during and after surgery with the rehabilitation to the definition of the patient by the patient himself of quality of life. So when you are into the brain, forget the tumor. Don't say, I will remove the tumor mass. It does not exist. It's a diffuse chronic disease. So please do intraoperative cortical and subcortical mapping, but most of all, the cognitive monitoring, and never technology will give you this kind of information, at least within the next years or even decade. And if you cannot operate without technology, that means that you are addicted. But in fact, you will not have this kind of results based on the connection between your brain and the brain of the patient. So my habit for more than 20 years is to treat the patient, not the tumor. I am a medical doctor. I am not an oncologist. I am a neuroscientist applying my knowledge to remove the tumor and then to give the opportunity for a patient to live longer and better. I am not really a surgeon. Now you have the choice. The question is, are you going to give the choice to your patients? Good luck. Thank you very much once again for your invitation and for giving me this opportunity to share my experience, but also my philosophy.
Thank you, Professor Hughes. It's an outstanding presentation, really an outstanding presentation. And I think talking on behalf of Professor Nasser, we would like to see you soon
حاجة اسمها ماك بوك.
when the COVID-19 situation is over. This is an outstanding presentation.
شوفوا
I
النبي.
think questions to the end, and we can proceed now to Professor Ayub talking about awake craniotomy in low-grade gliomas.
Thank you, Professor Rami. Well, we'll take questions or we'll proceed for my presentation.
I think Bassem, you say your presentation first,
Okay.
because the two presentations are related to each other. So you will give us your experience in Egypt about awake craniotomy, and then we open discussion.
Okay, sir, one moment. Wait, open. This is, I have some problems here. Okay. Here we go, share my screen. This is what I like to share. Share, okay. Start from the beginning here. Yes, I'm here. I'm just like, is my screen on?
Yes.
Yes, okay. Then I'm going to speak about a little bit basics about roles of awake craniotomy and low-grade gliomas. Well, what is low-grade glioma and which one awake craniotomy has to excise? Okay, if we know basically that gliomas are gluey supportive cells that support the nerve cells and help them function. We have like 4 types with strial cells, ependymal cells, which will not our concern today because this is causing tumor on the surface of the brain, and we have oligodendrocytes and astrocytes. These are the ones who are more or less inclined to. So the World Health classification, like subdivided into like 4 groups. Low grade, which is grade 1 and 2, high grade, which is grade 3 and 4. And this is mainly an histological classification. For grade 1, it's like there is no nuclear atypia, while in grade 2 there is. In grade 3, nuclear atypia and mitotic activity. Grade 4, nuclear atypia, mitotic activity, endothelial proliferation, and or necrosis. So these are the 4 grades. We are not concerned about the high ones, but we are going to speak about the low-grade ones. So the low-grade ones have different pathologies. We have this, like for grade 1, ganglioglioma, gangliocytoma, and other pyrocytic astrocytoma, this embryonic neuroepithelial tumors, while the grade 2, which is astrocytoma and oligodendroglioma, and a mixture of both. If we are speaking about the low-grade gliomas, we have to be inclined toward the spatial classification, where it helps us to remove in surgery. We have like grade 1, which is a solid tumor without infiltration, which is usually surgically amendable, and this includes pilocytic astrocytoma, ganglioglioma, polymorphic xanthoastrocytoma, and some protoplasmic astrocytoma. All of them having a solid core. So you just want an approach, you get the solid core, you remove it. There is no jeopardy for the function of the brain, so you don't want to have more mapping of it. While the one which is precluding surgery, example, most of oligodendroglioma, because they are mostly infiltrative. So if you remove it properly, you will see you make a deficit, especially in a liquid area. And we have one in the middle here, which is the surgical challenge one, which is a low grade, the grade 2 low-grade fibrillary astrocytoma, which has a solid core and infiltrative border. So you can remove the solid core, but still you have the infiltrative border, which you want to remove to improve or to cure the patient, but it's really challenging. So of all these low-grade gliomas, we are mainly concerned in awake craniotomy with the astrocytomas grade 2 in order we can treat them, because these are the one which is fitting the criteria of a solid center and an infiltrative borders. Before leaving this pathology, I'll talk about the immunological test recently, introduced in the WHO classification of 2016. This is the isocitrate dehydrogenase enzyme and IP1P and 19Q co-deletions. The co-deletions is an indication of oligodendroglioma, while the other ones shows us the aggressive the tumor. So if we have, this is the World Health Organization classification of grade 1 and 2, and we find that the grade 2 have been like split of the astrocytoma. When we have the wild type here, we should know that it's more or less aggressive, and we should treat it more aggressively in general. Oligodendrogliomas is categorized by the co-deletion, so we can differentiate these two ones from each other, which is really amendable for chemotherapy. So it's chemotherapy here is very helpful. And there was here an area which is mixture in the previous classification that now is no longer exist, because simply you can with these tests decide whether it's astrocytic or ganglioglioma, oligodendroglioma. And this is just an idea in some tumors of the astrocytic tumors, or the coming from the astrocytic line, the ID mutation and ID wild type, can give us a differentiation. For example, in the glioblastoma and anaplastic diffuse astrocytoma, we find that if you have a mutated type of IDH of a glioblastoma, the survival is better than an anaplastic diffuse astrocytoma with a wild type IDH. So we can see here that the expectancy is more in anaplastic astrocytoma rather than in glioblastoma multiformes, because the IDH here is mutated and here is a wild type. So it gives us idea more or less about the prognosis. So what's the management of these low-grade intrinsic brain tumor? The astrocytoma have lots of management, controversial, radiological, conservative, radiological, chemotherapy, combined radiation and chemotherapy, surgical excision. But oligodendroglioma mainly have a chemotherapy and to lesser extent the surgical and post-operative radiation. In oligodendroglioma, the role of surgery is for mass reduction, and if it's periphery, we can do also total resection. However, the astrocytoma one is the real challenge, as we illustrated before, because we have a central area of a tumor and surrounded by infiltration, and so we need to remove it and to remove the infiltrative parts. So surgical incision in astrocytoma grade 2, we have two entities we can say that away from an important area, which more or less needs no monitoring because simply you are in area non-eloquent, you can just remove it and things will be okay. But there is area which is nearly an important area which really more needs monitoring, especially if you are going to monitoring motor, speech, short speech areas. There is no like other things, as we will see later, that we can monitor speech except with awake craniotomy. So this is an astrocytoma more or less in the periphery. It's away from important area. You can just go here. You probably will be able surgically to remove it through a Transilien approach or whatever approach you like, and you will not cause the patient a deficit. So here the monitoring is not that important for these patients. But if we come to the other group, which is the near and important area, here where we know we need monitoring. And when we speak about monitoring, we surely have two types of monitoring, an electrophysiological, or I can say it's the physiological monitoring, which is the awake craniotomy, which the patient you have with him, with you, he's awake, you can monitor his movement, you can monitor his sensation and examine his speech, examine his higher intellectual function and see whether it's as Professor Hugo have demonstrated to us, and we can examine it intraoperatively. So awake craniotomy is just the patient is awake during surgery and he's alert and cooperative, and it's used whenever you are in near an important area. So what's the pros and cons of awake craniotomy? So electrophysiology, one is better because in aspect that better brain relaxation. You don't have the incidence of patients like straining, and then you have the increased intracranial pressure tension during surgery. So if the patient have fits, this will be also a mishap. You have to have a proper anesthesiologist with putting him to sleep for a while or change for general anesthesia. We have it's more convenient for the surgeon. The patient is not aware about your speeching and what you are doing, so you are more relaxed. It's more convenient for the patient because simply he's not here. He's just left, and when he came, he wake up and then everything is already done. But the physiology, which is the awake craniotomy, having advantage of two important things: the actual monitoring of functions. We have in somatosensory evoked potential. Sometimes when you do damage, it appears a little bit late. For example, in the spine, when we having somatosensory evoked potential and you're doing ependymoma, you can have the somatosensory evoked potential can remain intact for a while when you already did the management, and so damage. So there is a latency. But here in the awake craniotomy, there is no latency. It is real time. You do the things, you see the result. I'm going to explain the idea of awake craniotomy by an example of a case of awake craniotomy. This is an astrocytoma, which is near an important area, so it needs monitoring, and it's mainly near the speech area, which is sylvian mainly. This area is the sylvian. So probably it's related to speech areas. So you want to monitor the speech, and this is usually is not that easy concerning the electrophysiological monitoring. So this patient, having a female patient, 20 years old patient, having headache for the last 2 years and occasional attacks of vomiting. And this is her imaging. We can see how the tumor is, the size of the tumor, how it's big. So it's elevate the ventricle or distort the body of the lateral ventricle and extend to the temporal lobe. And it's mainly a Sylvian one. So here we do a functional MRI, and the functional MRI is giving you the idea about the relation of the tumor for the important structures. We have two, like with functional MRI, we can reach two situation. Either we find that the tumor is infiltrating the motor areas or the important area, as to say that you find its activity in the middle of the tumor. That means that this is non-operative. And you find that it is displaced or in the periphery of the tumor, or the tumor pushed it in its outskirts. So in this one, you need to do surgery, or surgery here is amendable with appropriate monitoring. Here is the function of the eye of this patient, where we can see that the hands and foot areas here are away from the tumor, because the tumor is in this area, and we have the hands and feet are really a little bit away from the tumor. So I think concerning them, the area of the hand and feet are a little bit away. But however, if we look to the internal capsule, we find that the internal capsule is just, going in this area or in the medial posterior part of this patient, of this tumor, I'm sorry, of the tumor of this patient. So here is the tongue. We can see the tongue area is here, and we can see that when there is a word generation, or the patient starts speaking with the patient, we see that these areas are more or less related to the tumor, the upper part of the tumor. So we have two important areas now we know is related: the internal capsule, which is like medially and posterior, and the word generation or speech pathway, which is mainly here we can see through these activities. So we should preserve this area, or to be like a little bit cautious when we are approaching them. So here is the monitoring. We should choose one, and probably in this case we're going to choose the awake craniotomy, because we know that in this case, in the awake craniotomy, we are going to have to monitor the speech in a better way than an electrophysiological can do. So awake craniotomy just some kinds of local injection of the brain around these points in order to anesthetize the scalp, and you could go on with your surgery. When you reach the dura, you should put some local anesthesia, because dura even with this local infiltrative anesthesia of the scalp is still sensitive. And whenever you are on the Neuro and a vessel, you should also put some local anesthesia, because the vessels are sensitive in the brain parenchyma, so the patient will get hurt if you manipulate internal carotid arteries, one of these ranges, without putting the local anesthesia on it first. So here is the patient while she is asleep, and then this is a 1 minute to show us the idea of it. We are operating on the patient. We can see her face, and we are asking her to repeat, to examine the speech. This was the last part of the tumor. We're just removing it slowly and examine every time the speech of the patient. Now we'll ask the patient to repeat some words, and then we find some sort of dysphasia. Ask her to repeat something, but she doesn't do it. So this when to stop the awake craniotomy. When we do a brain surgery for this kind of tumor, we have endpoints. One of the endpoints is the patient having a deficit. So when the patient starts to have a deficit, you don't proceed anymore. And usually this deficit, in most of our cases, all of them nearly have recovered in the coming like hours to days, 48 hours after the surgery. This deficit usually is reversible. So this is where we stop. If you have the patient start to have a deficit, another endpoint, sure, if by microscope you find yourself and your judgment that you removed all the tumor, there is no point of advancing more. By navigation, it's okay, show you that it may be helpful to you, but however, you have to be like corrected with real time, or intraoperative MRI if you have, but it's not available in most of the places. And this is the post-operative MRI of CT scan of this patient. And this is the post-operative MRI. We can see that we could achieve quite good resection, even most of the tumor. And I think probably there is some here around it, but at least 90% of the tumor have been removed. And this is the patient after surgery, didn't have any deficit concerning here, motor power or his speech or cognitive functions, because we had this like continuous monitoring. And the pathology was grade 2 astrocytoma. So here we have two ways of monitoring, either electrophysiological or I say physiological, which is awake craniotomy. Everyone having an advantage over the other one. So awake craniotomy, it is a good for real-time monitoring of brain function because there is no latency. You do the thing, you see the result. It is used mainly in intrinsic brain tumor, where you are near a eloquent area and you want to be safe, not to have this deficit. It is for us, it's cheap because simply, in our countries, monitoring of this area or monitoring of motor areas and sensories and other ones are really needing advanced monitoring, where sometimes we don't have it because it's expensive and needs lots of organization. Can monitor functions that otherwise cannot be monitored by other methods, because neurophysiology have a limitation. You have just sensory and motor one. What about the other ones? Is usually it's difficult to monitor. So this awake craniotomy have us to monitor these ones in real time, with real time. So in conclusion, awake craniotomy helps to safely excise infiltrative lesion near eloquent area after excluding the invasion by functional MRI. Thank you.
Thank you, Professor.
Thank you, Dr. Rami.
I think we should move to gliomas. And then we'll make the questions at the end.
Professor Dafu?
Hello. Dr. Rami, may I ask Professor Dafu for some questions, please?
Please proceed, Dr. Rabia.
Okay. Thank you, Professor Dafu, for this wonderful presentation, actually. And I need to know, based on your experience, is there any impact on the new classification of glioma, WHO classification, introducing the biological markers, IDH and IP19Q, in planning adjuvant or further management of low-grade glioma following surgery, or you think they were not having a role in this?
The answer is very clear, no. In our experience in Montpellier, in our network in France and elsewhere, the goal is to take into account many parameters. And as I told you, if the tumor is growing fast or slowly before any treatment, And this is much more reliable to predict which will happen following surgery. Second, the extent of resection. Of course, if I did just a partial resection because a too diffuse tumor like gliomatosis, like with a very wide invasion of the connectivity, so the limitation of neuroplasticity, we will do adjuvant treatment. But as I said, regarding the series of wild type, in 85% cases with a complete resection according to the postoperative flare, then we will not give any adjuvant treatment. Third, according, of course, to the quality of life needed by the patient. I mean, once again, if you do radiotherapy too early while the patient will live more than 10 years, you will have decline of cognitive functions. In all cases, we were absolutely sure yesterday about that in a webinar we did in San Francisco. Radiotherapy is dangerous because they will irradiate, even if they do focal irradiation, the connectivity, so the minimal common brain are not able to compensate in case of damage. This is the reason why we stopped into the operating theater. But radiotherapists don't know the function anatomy. And in the New England Journal paper, very famous with Buckner, with radiotherapy and PCV, you have just the mini mental status examination, remember, which was performed, which is an assessment initially planned for dementia. We are speaking about patients enjoying normal life and able to work. And in fact, they use an assessment planned initially for patients with Alzheimer's disease. And just within the 5 years following radiotherapy in this New England Journal, while we are following our patient for 20 years. So that means that if the patient is telling you, I would like to be absolutely sure to live longer, longer, and longer, why not? I will never make any decision for them. But if they are telling me I won't continue to enjoy a perfect normal life, I will say, of course, do not be irradiated following extensive radiation since the beginning, independently of the molecular biology. And once again, remember the paper by Monica Eggy herself, I cited the EORTC study. They start to say we have to postpone, defer radiotherapy for long-term preservation of quality of life. We are not speaking about glioblastoma for the next 2 years. Of course, if you have to irradiate, please do that. We are speaking about 20 years in advance. And young oncologists have not yet the habit to anticipate more than 10 years in advance, because in the vast majority of cases, the patient died earlier. So we have to change our mind. So molecular biology is just a part of the history, and change for us nothing.
So I understand you don't advise at all for early radiotherapy. But I need to know,
you should do the reverse.
Is there any rule for radiotherapy at any stage?
But you have seen in all cases that the famous Van den Bent paper I showed you in Lancet demonstrated, using evidence-based medicine, that early radiotherapy did not improve the median survival. So why to do that?
How can we deal with the residual part? And if the residual part is slightly increasing and it's not amenable for surgery, deep-seated or whatever, I mean, do we just wait for the patient or give chemotherapy or what?
Chemotherapy, which will not induce this cognitive dysfunction after 10 years. We have enough follow-up, and we did objective cognitive assessment more than 10 years after chemotherapy, especially temozolomide, and patient had no cognitive decline. So this is the reason why my proposal is to do chemotherapy first. And definitely, it's exactly the results of the paper we published recently in Frontiers Oncology, with more than 16 years of median survival, and not only related to the surgeon and surgery, but related to the fact that the oncologist I have the habit to work with for more than 20 years, first of all, will give chemotherapy in order to preserve the quality of life. And finally, we will be very happy also to have radiotherapy after 10 to 15 years, because we know that we cannot cure patients, and at that time, it will be possible to irradiate before malignant transformation, of course. While you know that if you irradiate it since the beginning, In 95% cases, they will tell you when you will speak again with your radiotherapist 5 years later, I cannot treat again. Yes, but now I cannot reoperate. And so what I have to do, I did my job, you cannot re-radiate.
Okay, if you decide to do stage surgery for a patient, how long do you wait for the second surgery until brain plasticity occurs?
Just the median is 5 years in my experience.
5 months. 5 years. Years,
Yeah.
not months.
No, of
Right.
course.
I mean, if
So
a
that
patient
means
has
that
a large tumor and I went it and took part of it, and I decided to do another stage surgery to remove the other part. How long can I wait, or should I wait until I go for the second part? Not for the current, I mean for the same patient at the same lesion.
we are not speaking about the same thing. I'm not speaking about a residual.
No, I'm
I
talking
left
about the stage
because
surgery.
the tumor
Yeah.
was too big. I left a residue, like in my example, for instance, because into the inferior fronto-occipital fascicle, so voluntarily. So I have no reason to come back a few months or weeks later because I miss a part of the tumor or the patient was too tired. I will, in all cases, remove all the tumor according to functional boundaries in my experience now. Of course, I was younger initially, and sometimes I had to do 2 stages, but because I was without any experience. But now I'm speaking about 2 or 3 stages, not because I left a tumor, but because I stopped according to functional boundaries, and finally, after many years, the tumor came back. It is not the same thing. And my secret, as you have seen into the movies, is that I do not remove the tumor from inside. I disconnect a part of the lobe under local anesthesia, meaning that even if the patient was too tired in the end, I have time to remove the part of the lobe disconnected, functionally speaking, under general anesthesia during the last part of surgery, and especially for the temporal lobe, because you can tell me some patients had pain when we are into the contact of the dura mater, of the skull base, and so on. But I will not do that under local anesthesia. I will first of all disconnect the temporal lobe very posteriorly at the level of the Wernicke's area to identify the hypophyse, the arcuate posteriorly, and finally, sometimes I removed maybe 20% of the volume while the patient was awake, but 20% around. And then I have all time to finish the resection classically at the level of the anterior temporal lobe under general anesthesia because I don't need the help of the patient anymore. So we have to change, you see, the mind of the strategy of surgery according to our knowledge of the connectome, and not just to continue to do from inside to outside. Otherwise, your patient will be tired when you will need really is help in the end into the contact of the more dangerous part of the brain.
Are all patients suitable psychologically for awake craniotomy, or you find some patients refusing this technique?
In my experience, prospective collection of data, more than 1,000 patients, I say no just in 3 patients because psychiatric disorders with psychosis. So you see that 3 for 1,000. It's very exceptional. But maybe I have a bias of recruitment. I should be honest also, because if the patients are coming from abroad in 90% cases, that means that they know before to come why they come, and vast majority of cases is please remove as much as you can according to functional boundaries because I want to continue to enjoy my life. So maybe I must be honest, it could be a bias.
Okay. In fact, I have some more questions, but I give a chance to my colleagues. Thank you very much.
Can I ask, please?
Yes, Professor Osama Al-Ghandour.
Yes, thank you very much indeed, Professor Daffio. Forgive me, I'm one of the old generations who are not very enthusiastic about awake craniotomy. But what I've seen from your work is that when you make the marking, the gyri and the functional areas, you're putting the number there. All the numbers you put on a normal gyri, and quite clear that the diseased part or the pathological part The gyri are very well demarcated, they are swollen, they are flattened, they are edematous, and even why should I take such a long time with doing that? I mean, I can, with the operating microscope, I can decline myself, especially if I use the fluorescein, so I would save time. The second question is, what is the percentage of recurrence after all you have done, after doing this, percentage of recurrence of these gliomas? Thank you very much.
All my patients will have a recurrence because I cannot cure them, as I said twice in my talk. So that means that it answers your fourth question. Unfortunately, you have a diffusion far beyond what we can see on MRI. And this is the reason why we cannot cure patients with glioma. This is a diffuse glioma. So more you can remove, including so-called normal brain, which is never normal, unfortunately, more you have to do that. Because how I know that? Because each time I did a supratotalization according to the functional boundaries, and sometimes beyond what we can feel surgically, in 100% cases, the lab told me, especially with IDH, there is tumors at this tumor and tumoral cells at this level. So that means that the most important for me is not old or new school. It's not awake, not awake. It's just results. And what I like is just to say, my patients are living more than 16 years and they enjoy a normal life in 99% cases with normal cognitive scores following surgery, objectively assessed by an extensive evaluation. So this is for me the most important. I am a surgeon in order to give them the opportunity to live longer and better, and not just to say, you have to use this technique, which is not a technique, but a philosophy.
How long do you give after your surgery to start the chemotherapy? Even if you made a total excision?
It depends. Yesterday, I reoperated on a patient. I operated on with 2 low-grade glioma, one frontal, one parietal in the left so-called dominant hemisphere, 10 years and a half ago. It was an astrocytoma. No chemotherapy, no radiotherapy. I did again a complete resection according to the flare. Of course, I did not cure them, but I say, we will again reoperate in 10 years. So that means that I have no protocol. My protocol is that adapt to each patient. I have no protocol. I do not use evidence-based medicine. This is the reason why my patients are living longer, including in comparison with the Buckner paper.
Can we proceed to Professor Hisham Bashouni from Germany? He wanted to ask a question, please.
Yes, thank you very much for this amazing 2 presentations. Well, I've got a bit difficulty with awake craniotomy. I'm not performing it personally, and but for reasons. First, I think the brain, the concept of eloquence and non-eloquence is actually not, it's simplification, because brain, every cell is eloquent. There's no things in vain. So everything has its function. I think according to at least my experience, when you are removing a low-grade glioma, and I'm d'accord with the concept that it is a multitask surgical issue, because what I saw in your video is Professor Osam has already said it, and I'm d'accord with this concept. It is a pale area what you removed. Actually, you marketed areas which I would not touch in surgery. I'm doing electrophysiological monitoring during surgery, but you see it, you feel it. It's the tissue is not normal tissue, and you hear it. So I think this is also what Yajagil has taught us, and he has presented very nice images pre and post op with radical. I don't like the word radical, but with so-called complete removal. We all know that it's not possible, but you can do it without awake surgery or awake craniotomy. And the other point you have already mentioned is the plasticity of the brain. There were on several occasions, on several conferences in the pre-COVID area when we still could meet, there were examples of awake craniotomies where the surgeon stopped prematurely because of edema which developed during the surgery, and which were because he entered a functional area but which recovered, but he left tumor which otherwise he could have removed. So I think this is also an important thing you have to consider while doing awake craniotomy. I'm not very. I know that, for example, Mitch Berger and you do it, and you're very propagating it. But I'm not so that convinced that it is an essential tool. You're right when you say that language we cannot monitor it in another way. Motor is another thing, but language is maybe difficult. But also in these cases, in patients who have who present with motor speech deficits, I observe after surgery, after removing it without awake surgery, that they are actually improving this task and not deteriorating. And if they deteriorate, then it's only temporary, because I think it is because of the plasticity of the brain, which you have demonstrated actually. Thank you.
First, I have no time to have edema because, once again, I'm not removing the tumor from inside, but as I say, I disconnect since the beginning according to the functional boundaries. Second, I did not speak about eloquent areas. I did that. I say that it was a networking and even a meta-networking brain. So we have perfectly understood that it's the relationships between different brain networks, and the goal is to push plasticity. Third, we have the proof. It's not I'm convinced or not, because we published the cognitive assessment about hundreds of patients. Fourth, Yazargil himself published his paper with a 5 to 10% of deficit. It's not my view. I have less than 0.5%. So if you prefer 0.5% or 5%. So I believe on numbers, long-term follow-up, cognitive assessment, return to work, and definitely the paper we published in Physiological Reviews is not just we think or not about brain processing. This is the Bible of physiological in physiology in humans. So that means that cognitive neuroscientists perfectly understood the principle of connectome far beyond eloquency, which is finally illusion of neurosurgeons.
But don't you think that I'm believing in this concept of connectome? I'm believing in it, and I'm convinced that that's right. You know the fascicles, of course, but don't you think that that anatomy is a very essential part in it?
Well, of course, this is the reason why I speak about functional anatomy. But in functional anatomy, you need to know the structure, but also the function. So just the structure is just a part of the history.
Thank you. Maybe Professor Mohammed Fahmy from Alexandria University, you wanted to ask a question? Is he still online? Dr. Mohammed Fahmy? Okay,
Hello?
Professor.
Hello?
Yes, okay.
Hello?
Proceed, Dr. Fahmy.
First, I would like to give a very big thanks for Professor Hugo for two reasons. He gave us a very nice presentation, especially he educated us about the recent advance in neuroscience. the problem is not only on cortical, but he showed us very well it related to the network subcortical also. It's very important recent advance of neuroscience, I mean, neuroanatomy and neurophysiology. This one point. Second point is I need to thank also for about a technical point, especially about, I am not saying for a lesser use of bipolar. He didn't use a bipolar. This is a very good for the result, of course. For me, this is something new I have been educated today. The last thing I need to make a remark about, there's a very big difference if you are working on a high socioeconomic country or a good economy and a lower mid-class economy. I am talking from Alexandria, Egypt. Egypt is oldest civilization on earth. This is right. However, we are considered by the United Nations as lower mid-class from the regard of economy. And this is very important because in some hospitals, we don't have a lot of this recent advance of equipment in every OR or neurosurgical operating theater. Last, I would like to welcome him in Egypt, of course, in Cairo or Alexandria University. Thank you.
Thank you for your positive feedback. I would like to insist regarding the younger neurosurgeon that indeed I did this kind of surgery with a fork and a knife in North Africa and Middle East. So I don't need to be in Montpellier to do that. And I trained 600 departments of neurosurgery coming from 60 different countries. In all cases, they were able to reproduce exactly the same results without any technology, but just their knowledge of the functional anatomy. So that means that if you can do that, you can do that everywhere in the world. You don't need to have billions of euros in order to preserve the quality of life of your patients. And I think that this is really the message.
This is very nice and this is very good. But in Egypt, we have a lot of young neurosurgeons. They wanted to see you maybe working in Egypt one day. Okay, thanks.
But first of all, they have to come. Once again, I welcome so many countries, and to be honest, so few people coming from Egypt. First of all, they have to come to see the team, because it's not just me, but the neuropsychologist before, during, and after surgery, the anesthesiologist able to do a sleep-awake, a sleep procedure with 99.9% of reliability, and so on. So this is very important to understand that we need really not to have money, but to have a good team.
Yes, I understand that, and we can cooperate with your center, of course. Thanks.
Professor Dafo, I wanted to ask a question. You use the blue light using with the microscope and injecting a dye to delineate parts of the tumor that in low-grade gliomas that might look similar to the brain.
Of course not, because as I said, I forget the tumor into the operating theater because I know that everything more or less is tumor, and especially in high-grade glioma. I spoke about low-grade today, but I have exactly the same habit in glioblastoma. What I do is not to remove the enhancement, but is to remove more according to the functional boundaries. So more you remove, more you will have an impact on median survival. I remember I published a paper about the concept of supratotal resection in World Neurosurgery 7 years ago, by telling if you can remove more than the enhancement, the patients are living 3 years, in my experience, speaking about glioblastoma. And finally, it was reproduced about many patients in the MD Anderson 2 years ago, and recently by Mitch Berger. So that means that the goal is to forget really the tumor and to remove according to the connectome. That's it. do not try to identify the tumor for younger people. It does not exist. We speak about diffuse glioma, and it has been demonstrated, of course, by Pat Kelly and Catherine Demas-Dupont 30 years ago, thanks to multiple biopsy. So that means that if you do samples like this, you know that you have tumor cells everywhere. So the goal is to remove more, and it's possible if you preserve the quality of life. And I disagree with your fact that everything is functional into the brain, because they have a brain tumor and because they can use the contralateral hemisphere in order to compensate. And this is demonstrated by the fact that if the neuropsychological examination is almost normal before to go to the operating theater, that means that the part of the brain invaded is not eloquent anymore. So we have to play with the dynamics of network and not just to say everything is functional. On the other hand, everything is functional in the normal brain. This is the reason why we have to awake in all cases, whatever the location, and not just to say the right frontopolar part of the brain is not eloquent. Sometimes you have more risk to induce modification of the personality by doing this lobectomy. But to be honest, in the series by all neurosurgeons, never they spoke about that.
Thank you. Yes, Professor.
Yes, there is two questions from India.
India, okay.
Dr. Rami.
Please proceed.
Yeah. Yes. There's two questions from Harshad from India. The first question, Dr. Defoe, he asked about the cases of glioblastoma vascularity. It is seen how you control the bleeding and how you demarcate the borders. The second question is, how do you control seizures if it occurs during surgery in awake surgery? Thanks, Dr. Duff.
You can believe me or not, but once again, I have visitors for 15 years for almost all my surgeries, so I cannot lie. The rate of aborted awake surgery, speaking about more than 1,000, especially related to edema or seizures, is 0. Because I use very low intensity between 2 to 3 milliamps and not 10 milliamps as in the classical literature. So no seizures. So it's not an issue. If you have seizures, that means that you do not use the stimulator as you did. Second, in glioblastoma, I have no bleeding, because once again, I will not remove the tumor from inside. Of course, as everyone, if you have enhancement, and if it has I aspirated the enhancement, I will have bleeding, but I will turn around by doing a lobectomy outside the enhancement. And if you do that, you can do exactly like in my movie. I mean, without any bleeding, and finally you remove everything monoblock. It's not always possible within the insula, but in 90% cases, this is possible by doing a lobectomy. And of course, in the middle of your lobectomy, you have the enhancement, so no bleeding.
Concerning the inversion, the change to general anesthesia. Well, I have not that immense, experience as a doctor, but from my point, I have like 30 patients in which I was obliged to make a general anesthesia because they were not, one was not cooperative and the other one went into seizures. Although it wasn't in the stage of stimulation. We were a little bit after and we were like just removing the tumor and the patient had seizures because we were near the motor cortex. And in both cases, we did like change the situation to general anesthesia. And one of the things is that sometimes they are not that cooperative. The other case was not cooperative and the guy was training and the brain was going to herniate. So awake craniotomy is not an easy thing. But if you just like put the brain itself until the anesthesiologist quickly sedate the patient and he doesn't intubate, he just put a laryngeal, intubation, that probably will be sufficient at that time. So this is the two cases I had in my 30 patients or 31 patients, like problem with them. So if this helped the guy who asked this question, because sure we don't have the equipment and the knowledge of the team of the Professor Dufont?
As you said, the team. And this is the reason why we are doing this kind of surgery 4 times a week. That means that anesthesiologists have their experience like I have my surgical experience. And of course, I said many times that I have so good results, the team work. And I can tell you when your patient is not collaborative, that it's a problem of anesthesiology and your psychologist. And this is the reason why I have all my patients very collaborative, because I have very good speech therapists, neuropsychologists, anesthesiologists taking care of them beyond the surgical issues.
Concerning the comment of Dr. Basuni before he asked about the awake craniotomy, I think you should try it, because previously I didn't use it, and usually end with a more or less a big, residual. Awake craniotomy, you go until one of the things I told you happens. You have a starting a deficit, you have like completely reached the tumor's end. So this thing make you remove more. Previously I used this one I presented, you see more or less I removed most of the tumor or nearly total, but the other ones previous to using awake craniotomy, you could see my result. There is a great difference between both of them. It's apparent. So awake craniotomy will sure make you an advantage concerning removing the extent of removing the tumor. So I think this is you should think about it.
Well, I'm also not taking a biopsy or extended biopsy. I'm doing a radical surgery, and of course we are doing an immediate postoperative on the day after surgery. We are doing an MRI to judge, and of course you have to judge the flare sequences and not the T1 in order to see what you have removed. And this is a radical removal I'm talking about, but my judgment is primarily the surgical task. It's yeah, as I said, it's the visualization. It is the tissue is different. The infiltrated tissue is different from normal brain, and also you hear it with the suction actually. So this is this I'm guided with, but I'm not contradictory to awake surgery. I'm not against awake surgery, but well, as you yourself said, it's not an easy task, and you have got you have to have a very experienced team, of course, very good players on the anesthesiological side, on neuropsychologists, and so on. So it's a teamwork, and so to have a good result. And actually, at least as far as I know, in Germany, it is not done in also in institutions. So I think most of the institutions worldwide are still doing the so-called conventional neurosurgery. But this is not talking against awake surgery. But believe me, also without awake surgery, you get good and results, functional results, and also MRI results, and also long life quality and long living patients.
This is the last point, because I know very well colleagues from Germany. I gave a talk in Berlin just 2 weeks ago. What I would like also to see, to convince me, is not only the median survival, but the cognitive scores and the return to work. So not only the extent of resignation.
Yes, it's right. Life quality has to be, and I'm following up personally to my patients. I'm not leaving it to anybody else, because I want to know what was the quality of my surgery. So I'm personally following them up, and also as far as it is possible, I'm doing logopedic evaluation. What is the quality of speech before surgery, after surgery? So you have to be behind and of course, not only see the images, not only see that the patient is living, has no motor deficits, but also the functional and cognitive aspect of the, and of course, quality of life includes working quality also, of course. Yes.
Dr. Ashraf Al-Abed, he want to share and to ask question, please. Dr. Ashraf.
May I ask Professor Hugo? I understand that you use low frequency stimulation in your cases, and you don't prefer at all the high frequency or 10 of 5 in some cases, or I mean, is there an indication for each of them, the low frequency or high frequency, or you prefer the low frequency all the time?
All the time, because that works. I'm very empirical. 60 Hertz, I learned from George Hodgman directly in Seattle. No seizures, sometimes maybe, to be honest, 2 to 3%, but with partial seizures for 5 seconds, you irrigate, you know the trick with cold serum, and that's it. So aborted surgery, no. And positive mapping in 100% cases. We disagree with Mitch Berger with that, because I prefer to have wider bone flap in order to identify the ventral premolar cortex since the beginning and to know the threshold, and most of the time 2 to 3 milliamps, and that's it. Why? Because in fact, I speak about mapping, but the most important is the real-time cognitive monitoring.
Okay. I mean, so you never met the problem with seizures during low frequency stimulation?
Pushing to abort surgery, never.
Regarding anesthesia, I mean, do you just do scalp block anesthesia, or you do use intravenous sedation as well for the anesthetist? I mean,
we do asleep, awake, asleep, because when I was younger, coming back from Seattle, I was still in Paris. I did awake, 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 and the patient was tired because he had to wait for my opening, and sometimes he had pain. Now we have a very good team, once again, for 15 years approximately, with laryngeal mask for the opening. The median before the awakening of the patient is 7 minutes, and then you can do very extensive neuropsychological examination. The patient is not tired, and then you can push the number of tasks you do simultaneously in order to preserve executive function, emotional processing, behavior, and not just movement and language. And in the end, as I told you, we put a tube and you have all time, if you want to remove the temporobasal part into the contact of the dura mater, and then no pain. So this is, to my opinion, the best way, because I have tried both, and it's very convenient for the patient. I have listened another colleague telling it's not very comfortable for the patient awake mapping. This is totally untrue. The patients prefer to be under local anesthesia because they can control online that they have no deficit. And what they want is to avoid any permanent deficit for the next years. This is the most important. So they are quite into the OR. And me too.
All right. I understand that you don't believe at all in pre-operative functional localization by functional MRI and tractography.
I would say that it's not, I believe or not. It has been demonstrated by the specialists in this field recently. They know that this is totally untrue. And if you go
the problem is the technique itself,
for instance, they will tell you, do not trust on that.
You think the problem is with the technique itself or the interpretation of results?
Both.
Both. I mean, we are building our experience here in Egypt in intraoperative monitoring and surgery for eloquent areas. And actually, I find functional MRI a little bit helpful pre-operatively in planning craniotomy, in finding where should I start mapping. So do you think while we are building our experience, we might find the functional MRI helpful until we get, the whole experience, and then we can don't use it at all after that?
I will tell you why it's dangerous. Because as I said in my talk, the vast majority of patients I operated on were not selected for surgery by other surgeons in the rest of the world based in the vast majority of cases on fMRI. That means that in your practice, you have a selection of patients considered as operable according to the pre-operative fMRI. But you have a vast majority of patients. Finally, it would have been possible to remove the tumor against the results of preoperative fMRI. And I know that because this is my practice. And never in the classical beautiful papers telling, yes, we use fMRI, you have the rate of patients not selected for surgery. But these patients continue to have a brain tumor, which will kill them.
Okay, thank you.
I think Dr. Dufour using new techniques and new theories, and I think we are still need a time to learn it, not in one lecture. And for the sake of the time, we need to shift to the last topic by Dr. Dufour on the insular surgery. Yes, please, Doctor.
First of all, it's not a new technique because Penfield, I must confess that 1 century ago, it was used. When I met George Hirschman, it was 25 years ago, that we pruned with Mitch Berger, the use in gliomas for 20 years ago, and the principle of connectome in the field of cognitive neuroscience, because I am also involved in this field, is very famous for 10 to 15 years ago. So that means that, in fact, for neurosurgeons, it seems to be new, but in fact, it's because there are, and I don't know why, walls between different specialties. And this is the reason why sometimes I have the feeling to be schizophrenic, because I live in the same world, but I was in a meeting of cognitive neuroscience 1 week ago, and I will deliver a lecture in the plenary session of brain and language meeting in Philadelphia, of course, via webinar in 2 weeks. And it will be an evidence that plasticity exists, that we can use the contralateral side, that we have to see interactions between different networks, that we can push by using TDCS or TMS before surgery, and that, and so on and so on. And that functional imaging is just a didactic tool and a research tool and not the reality at the individual level. And suddenly I switch to a neurosurgical meeting, and it seems that everything is new and should be demonstrated while it has been demonstrated. So my message for insular surgery is that if you know where to have a surgical approach through the operculum, because Broca's area does not exist, and you can go through the pars opercularis or triangularis of this patient at that time according to the mapping, because the brain is not the same from one patient to another one or in the same patient over time, you will have 99% of reliability, while I reinsist, we did really recently a meta-analysis of the literature using the Transylvian approach. It's not my results. The risk to induce severe permanent deficit was 5 to 10. So do you prefer 5 to 10 or 0.5%? And that's it.
Maybe, maybe I just want to comment on functional MRI and fiber tracking. I think we have to differentiate between two things. I would never judge operability or non-operability on these tools. That's the first thing. But in planning surgery and planning the approach, for example, they are helpful. But you have to keep in mind that the spatial resolution is not good. You have also to keep in mind that they are also indirect visualization because of the techniques, the bold techniques, for example, in the functional MRI. So these are not direct visualizations. So you have to keep in mind that these techniques may be failing or leading to a false impression. but I think they can be helpful in planning surgery, not in deciding whether the tumor is operable or not operable, but in planning surgery and especially in planning the approach, it is helpful.
Of course, for planning your mental imagery, I will not say the reverse, because probably I was the first surgeon in, I'm sure, in the world to start to use DTI in 2000, just after the publication of the MRI Atlas. And I had a poster in my office, and before and after each surgery, I tried to understand where I was 20 years ago, but in my mental imagery. Why the problem is today, when we start to say we will use fMRI and DTI, means that for the young generation, even in Montpellier, I have to be careful, they will become addicted of this methodology. And they will not use it in order to build their mental imagery independently as a didactic tool, but they will be dependent on the results of the preoperative DTI, fMRI, and intraoperative navigation, just as a kind of psychotherapy. And I traveled a lot in my life, and sometimes in big institutes, and they told me sometimes you will have many people for your conference because today the neuronavigator is broken and we had to postpone surgery. And I said, please, can you show me the tumor? But I can do that with a finger just in 10 minutes if you want. So be careful about, yes, we have to use tools to build our brain versus we are becoming dependent on technology.
Yes, it's exactly. It's just a tool. It can help, but you should do it with navigation in your mind. That's right.
Yeah.
And as last Lexel said it, fool with the tool is still a fool. And so that's it's just a tool, and but you have to depend on other means. Yes.
Are you ready, Dr. Dafu, for the videos on the insert surgery? Are you ready for that?
If you have time, I have just 10 more minutes. Yes. If you want,
yes, yes, please.
Yes. We need to learn everything today.
Today it will not be possible, I'm sorry. Sorry, I would like again to share my screen, but I had some problem to share. Okay, can you see it now?
Yes, now, yes, perfect.
Okay, perfect. So it's and we go a little bit faster. A classical left frontotemporal insular tumor, low-grade glioma in a patient with seizures, normal clinical examination, but on the preoperative cognitive assessment, he had some disorders regarding semantic processing. So I have the habit to do a surgery under lateral position, right, left. So the patient, as I told you, is under general anesthesia for the opening with a laryngeal mask, propofol and remifentanil. I put a methyl, so that means that if you want, nonetheless, because you're younger, to use your navigation, you can. Everything is compatible with everything. I would prefer a big button flap. I will not insist about that, but it's a discussion, as I said, we had for many years with Mitberger, because I will have a positive mapping and never the size of the score. What a problem with my patients, speaking about more than 1,000. I will do a local anesthesia in addition to at the level of the skin and the dura mater, a trick I learned from George Oshman, so no pain during surgery. And the patient now will be awake while I'm opening the dura mater in order to finally do the cortical mapping. And you can see here that, of course, you have the Sylvian fissure, that you have the superior temporal gyrus, that you have the ventral premotor cortex, and again, so the lateral part of the precentral gyrus, which will give anarthria, speech arrest, as you use the term you want, but 60 hertz, 2 to 3 milliamps is enough in order to induce speech arrest. And of course, we will map the so-called Broca's area, passopercularis, triangularis, orbitaris, and nothing will happen as in the vast majority of cases. Of course, you can tell me, you can see the tumor here, and to use this surgical approach, and I will answer no, because I will remove more by doing a supratotal resection. And once again, I have more than 16 years of median follow-up, median survival with a prospective collection of data, and this is unique in the literature, not just speaking about a couple of cases by telling I follow also patients with more than 20 years. Of course, 80% of my patients are still alive because I will remove more. And I can tell you that if you have the feeling when you remove this part of the brain, which seems to be normal, and you refer it to the lab, it will tell you in 95% of cases, I identified tumoral cells. So the goal is not to remove a tumoral mass because it does not exist. This is a diffuse glioma. More you remove, more the patient will live longer, but not against the quality of life. So awake mapping. So now everything is clear. So I will do just a cortical, I will use, the bipolar to do a cortical coagulation, and that's it. Now I will preserve everything, including, of course, the veins here, because you can see that the drainage is not just at the level of the superficial temporal vein, but at the level of the prefrontal area. And the goal is to do subpial dissection. You can see very quickly, because this is real time, that it will not bleed, that I have not to coagulate anymore, and that you will see very quickly the surface of the insula in less than 3 minutes, and then you will have a beautiful access to the insular part of the tumor by removing this area, which is also involved by a tumor as confirmed by the lab. So, of course, what you feel macroscopically speaking is not the truth of the chronic disease, but just the tip of the iceberg. And you can see that you have no bleeding. You can see that everyone can do that. You can see that you don't need to be skilled. And you start to see here the surface of the insula with the vessels. And very quickly, so I will be able to remove the pars triangularis, then the pars opercularis, then the pars triangularis, the orbitaris. You can see what happened. Okay, here you have still the veins. Here you have also the removal of the superior temporal gyrus, of the so-called Broca's area, which does not exist. The patient is doing a dual task, naming, a semantic association task, a movement, and never I will be into the contact of the vessels, because you have pia matter everywhere around them, explaining why I have no spasm. And once again, the goal will be to identify the pathways with the inferior fronto-occipital fascicle in the depth running the temporal stem, and posteriorly the pathway involved in articulatory processing, but also the control of movement. And this is the reason why we start to stimulate in the depth. Here you can use the retractor, but I will use it by hand. That's it. And I do not retract the brain anymore because there is no brain anymore at this level. So it's just in order to do a subpial dissection within the insula itself without any coagulation. As you can see, definitely I will never coagulate within the brain. So I had no any vascular problem for many years. I touch wood. So it was a video I did a few years ago. That means that I do not use CUSA anymore now. I do everything with the succer, but of course, just a tool. And if you like the CUSA, you can do it. But you increase the risk of spasm, speaking about the vessels. So now, all dissection have been done. You have seen that the patient is not tired, and I will start to stimulate, so in the depth. And this is the most important for you to see now. I will show you again. You see that the patient is speaking. The patient is naming. The patient is moving. The patient do that every 4 seconds. You have seen that the movement was not exactly the same. It's not hemiplegic, yes, no, it's a control of movement. Because the patient told me, I like to do sport. You see what happened? I stopped the movement. This is not a pyramidal pathway. And the patient stopped to speak. This is the conjunction between the lateral part of the superior longitudinal fascicle, the fat, and the frontostriatal tract. If you have everything in your mental imagery, you know the structure, you know the fasciculae, you know the anatomy, but you know also the function and the interactions. And at that time, you know that you have to stop at the dorsal pathway. Then you have to do exactly the same thing at the level of the ventral pathway by doing a stimulation at the level of the inferior fronto-occipital fascicle. And I will stimulate, and you will see that the patient will have a problem. Now, this is not the dorsal pathway. This is the ventral straight. Okay, semantic. So it's not just because I don't know the anatomy. I know very well where is the structure at this level. But I want to have the function too, because in the brain, the connectome is structure and function. Brain structure and function. And again, a blocking, you have to stop. And if you continue to cut it, you will tell me the patient is able to speak following surgery. Yes, but I will tell you, I would like to see the post-operative cognitive assessment, and the patient will have problems regarding semantic disorders. And then he will not return to a perfect normal life. So now I know that I have to stop. I discuss with the patient by explaining to him that we reached the functional boundaries, and then the patient will be under general anesthesia, and I will finish to remove this part which is disconnected under general anesthesia because there is no function anymore at this level. And just a dissection without any coagulation, without splitting the Sylvian fissure, blah, blah, you have understood. So I will show you the post-operative MRI, which is again through the so-called Broca's era, which does not exist, with the temporal lobectomy, with the insular resection, and again a residue voluntarily left. And here you have the inferior fronto-occipital fascicle and the anterior perforating substance, namely 4 cc of residue, 95% of resection, with a volumetric assessment on the FLAIR MRI, and the patient we have now 8 years of follow-up, no chemotherapy, no radiotherapy, and of course the tumor in the depth grew, but very slowly, despite the fact that this is an IDH1 wild type. So if I can do that, you can do that with almost nothing, just your knowledge of the functional anatomy, but also the feedback provided by the patient in real time, thanks to a good team and our knowledge of the Connect tool.
Thank you very much, Dafo. It's very illustrative videos, actually, and it's very great experience. Omar, do you have any more questions in the panel?
Yes, there is here a questions from Harshad. He speak about the safe margins in case of extensive resection, for safe resection in case of eloquent areas.
But functional boundaries we spoke about since the beginning. This is the point. The vast majority of neurosurgeons have no idea about the functional boundaries because they don't know the functional anatomy of the brain. We have to be neuroanatomists first neuroscientists, and then neurosurgeons. And then everything becomes an evidence because you have seen that I have no bleeding and I am not Yazargi. So if I can do that, you can do that. But you have to know how the brain is processing.
And I find you, Dr. Dafoe, you are not using the microscope. Is it true?
Of course, because the risk with a microscope, and I have seen that with my masters, is to try to fill the tumor and to cut the pathways in the depth while they have no the 3D holistic view of the connectome. This is very dangerous. And once again, this explains why in the classical literature by masters, the rate of severe permanent deficit was 5 to 10% and not 0.5%. Our goal is primum non nocere.
May I ask question, please?
Yes, please go ahead.
Regarding the regimen of follow-up, I mean, how often do you ask for MRI follow-up for this patient and for how long?
Every 6 months, all their life. My first patient I operated on was 24 years ago. I can tell you that she's still a nurse and she had a baby who is now at the university and so on. So it's ad vitam aeternam. I have not cured this patient and I need to extend my follow-up beyond 30 years if I'm still alive in 10 years.
Thank you.
Any other questions from any of our panel lists? Hisham, do you like to ask anything?
No, thank you very much. It was an amazing webinar. Thank you very much for this insights, and we're still learning and keep on learning.
Thank you very much.
As long as we're alive.
Thank you very much. I think it is time to close the webinar. At the end of this webinar, I would like to express my sincere appreciation to our speakers, Professor Dafoe Hugues from France. Really, you honored us by contribution to our webinar and giving much of your experience. Thank you very much, Dafoe, for coming and for accepting my invitation. I'd like to thank Professor Bassem Ayoub, Professor at Cairo University. I'd like to thank Professor Ashraf El-Abyad, one of the eminent neurosurgeons in Egypt and specialized in functional neurosurgery, Professor Hisham Basyouni from Germany, Professor Osama El-Ghannam, Professor Fahmi Zaid, and I'd like to thank our moderators, Professor Omar Youssef and Professor Rami Amin for moderating this session. Thanks to all attendees. Thanks to Utopia Pharma for organizing this webinar. Thank you very much to all of you.
Thank you. Thank all of you. Thank you.
Goodbye.
Okay,
Goodbye. Thank you.